I invite Dr. Subrat K. Acharya, Dr. Mazimu, Dr. Rakesh Kapoor, and Dr. Naveen Kalra. Join us on stage. And it's a request that due to paucity of time, at 7 we have GBM. So let us keep ourselves within the time limit. Thank you.
Since we don't have time, without delay, we should start this session on primary liver cancer, essentially the advances in management. And to speak, the first speaker is none other than Professor Prasun Jalal from Baylor's College. Prasun is, I think, known to this audience. He is a product of PGI and is now Professor of medicine in charge of liver disease at Baylor's. Prasun,
yes,
you will speak to us. What is the therapeutic implications of molecular classifications of liver cancer? And this very specific question, does it have therapeutic impact, the molecular classification?
Thank you, everybody. And thank you for the kind introduction. Coming back to PGI means a lot to me. But the topic is, a little bit beyond our regular day-to-day practice. So we'll see where do you go. So therapeutic implications for molecular classification. So what we already know, the worldwide liver cancer is the 4th most common cause of cancer-related death. The WHO estimates that more than 1 million patients will die from liver cancer in 2030. The United States, it's going up 43% based on the data between 2000 and 2016. And 5-year survival rate is 18% only. So that's, second most lethal tumor after pancreatic cancer. Well, that's all we know. So what we can do about it? We can learn. So the classic story is non-small cell lung cancer. Before 2004, the prognosis was dismal. Before they figured out there are EGFR and other mutations which can target. Now the prognosis is way better. So there are precedents, like in bile duct cancer, although again its prognosis is dismal. But I think there are multiple drugs coming, and hopefully it'll get better and better. So things are happening in this area. What can do for the liver cancer? Well, the molecular classification may help. It can identify aggressive subtypes, so target the treatment, and it can do, basically you can go for aggressive tumors in a more defined way. It can help in precision medicine, exploiting the vulnerabilities and specifically designed to subtypes. We can improve the clinical trial design. And so specific molecular subtypes, depending on the treatment response and prognosis. And very importantly, we can develop new biomarkers and refine the staging system. If you know, at the moment, HCC staging system, BCLC or whatever we have, is based on tumor volume. And that's very primitive, and we need to do better. So this, I don't expect you to look at the chart on the right side, the figure, but I want to remember you the colors. The red is Mendelian inheritance pattern, like HFE gene, Wilson's disease. The blue is the polymorphisms, which we are going to talk about, genetic polymorphisms. Green or yellow is environmental and genotoxic exposures. Think about Hep B, Hep C, aflatoxin. The purple is the potential strategies to reduce HCC incidence. So, again, the color codes. Going to the right side, as I mentioned, look at the Mendelian inheritance pattern. So definitely including in fatty liver, PNPLA3, the different, the pattern is there. Then look at the environmental and metabolic factors on the right side. These are the causes for liver cancer and liver disease, including alcohol, metabolic syndrome, viral hepatitis, aflatoxin, and so on. That leads to our next step. There are multiple mutations, especially TERT and P53. So these, the whole gamut of polymorphisms are involved. So there is significant molecular heterogeneity in the development of HCC. That's our problem. And it's a multi-step process. If you look at the left-hand side, in cirrhotic patients, and the right-hand side is non-cirrhotic patients. Remember, HCC can develop in non-cirrhotic patients, not only in hepatitis B, but also in MASLD and many other conditions. So, including hep C. So, on the left-hand side, the most important mutation, somatic mutation, is TERT, promoter mutation. It happens at least in 60% of HCCs. It starts early. If you see the nodule gets dysplastic, a small nodule, then large nodule, it's always remodeling going on in the liver. So inflammation leads to fibrosis and remodeling. And whenever there is change into the malignant transformation or neoplastic transformation, the first rate-limiting step in a cirrhotic patient is TERT mutation. Then other mutations come, like TP53 or beta-catenin. On the other hand, on the right side, if you see that beta-catenin mutation comes first, and then, especially if you think about adenoma, hepatic adenoma, you think about it. And then later on, the TERT promoter mutation comes. So what is TERT for layman's term for us? So it's a telomere is a repeat sequence of DNA. At the end of the DNA, it is there. And it helps in, it shortens, as you know, during the cell division, leading to cell senescence and apoptosis. And telomerase is the enzyme which is required for telomere synthesis. And the TERT is the enzyme which helps in the synthesis of the telomere. In the human liver, telomerase is not expressed. On the other hand, is reactivated in most patients of HCC. As I mentioned, TERT promoter mutation earlier, and also have TERT amplification, and hep B virus can insert into TERT promoter as well. So this is the rate-limiting step for most patients, especially in cirrhotic patients. To summarize, it's a multi-step process in carcinogenesis for liver cancer. On the left-hand side, you have the single nucleotide polymorphisms. On the right side, if you see the host factors and also multiple genetic mutations, somatic mutations, which can happen. So there is another way to classify the liver cancer. As I mentioned, that we need to do the staging and classification in a different way. So we have this entity has come up, proliferative and non-proliferative. So aggressive, non-aggressive. What does it mean? So higher rate of chromosomal instability, higher AP level, poor differentiation, and lower survival. Think about hepatitis B. On the other hand, when it's non-proliferative, that's less aggressive, lower AP, lower recurrence rate, and well-differentiated tumor. Think about hep C, alcohol, even NASH. If you look at this data for looking at the druggable targets in liver cancer, see, HCC goes at the very bottom. So out of all the cancers, we haven't achieved a great success, especially targeting this host of somatic mutations, which I have outlined. So the landscape of mutation of HCC, if you see the genetic landscape of common forms of human cancer on the left side panel, is the Vogel's present in publication. And genome sequencing in HCC is out of 243 patients and 160, more than 160 driver mutations. But look at this, TERT, P53, all these are not druggable. On the top of it, there's significant heterogeneity in tumor cell growth in liver cancer. So it could be within the tumor, it could be with metastatic areas within the HCC, like multiple centric tumors. It could be between different heterogeneity between different patients. So bottom line is, within the same tumor, there could be significant heterogeneity. So histologically, if you see, when you're biopsying, unfortunately you don't biopsy because of radiological improvement. However, we should think about it, especially when you talk about targeting HCC treatment. So if you biopsy, think about it. 3 centimeter tumor, you're biopsying 0.16 of the volume, then you have only 1.1% of the actual tumor. And larger the tumor, less is the amount of the specimen which is eligible for analysis. So the challenges, the heterogeneity is there, clinical, tumor, in the tumor microenvironment, limited tumor tissue for diagnosis, few validated biomarkers, poor prognosis due to detection of advanced stages. A lot of patients come to us with advanced stages. So that's why the prevention and surveillance is very important, especially in a high-risk patient. Then difficult tumor type to which develop the oncological therapies. So at the moment, what we have, there has been significant changes, evolution, the systemic and local agent treatment, and especially immunotherapy landscape. Think about it, until 2007, we didn't have any systemic treatment which is focused on HCC. Since then, huge number of drugs have come up. Of course, we have improved this in survival, but not a huge amount, but still, I think it's the step to the right direction. Think about it, from a few months to going for a few years, and hopefully it'll continue to get better. So it's very important to identify the immune-specific class of HCC because immunotherapy is going a big way. So approximately only 25 to 30% of early-stage HCC have genomic evidence of immune activation. 25% have, immune, I would say, they are either, they're not, there is no immune system there, which is targetable for treatment. And if you look at the right-hand panel, the immune, they have this immune-rich system, the prognosis is bad. However, the treatment is there. So with these types of HCC immune classes, you can target them. The immune active class associated with responsiveness of immune checkpoint inhibitors, whereas the intermediate group or deficient group, they are not. So we can specifically target, again, only 25 to 30% of HCC patients are targetable that way. So where do you stand with advanced HCC? Dr. Finn will come back and explain it much better way than what I can do. So, but all I can say that multiple immunotherapy treatment are coming and is getting better. So at the moment, it's not just immunotherapy, but also use combination therapy with multikinase VEGF inhibitors. See, all these drugs have been approved or in clinical trials. So systemic therapies, we know this algorithm at the moment. We use checkpoint inhibitors and multikinase inhibitors, and if they have got problem with the varices, we have second-line treatment, or even with multikinase if they have autoimmune problems. However, the challenge is this. Think about it. We are at the stage of stage 1, phase 1, maybe phase 2. But there is a long way to go, specifically targeting different mutations. So combination therapy also works within the immunotherapy system. So it's not just the anti-PD-1, but also a combination with anti-CTLA-4, that helps because that increases activated CT8 cells. So it's within the immunotherapy we have to use in combination. So right combination matters. So right now, we are combining immune checkpoint inhibitors and anti-VEGFs with all these trials going on. And again, I'll leave it to Dr. Finn to outline this in a much better way. So with that, I can say that things are getting better, but we have a long way to go. The gene signatures. So look at this. We know the standard therapy right now is atazobihor. The tumors enriched with immune-related signatures, if there are 3 signatures, their prognosis is much better. Whether if they don't have those signatures, this is from the tumor tissue. They have got significant high expression of VEGF antibodies, genes, and they don't respond to immunotherapy. And you have to use the VEGF antibodies or similar drugs. So looking ahead, what you can do? So you can do the next generation immuno-oncology and different combinations with checkpoint inhibitors. On the right side, we have some examples. The novel molecularly targeted therapies. We can use radiotherapeutics, antibody-drug conjugates, and more targeted therapies like beta-catenin inhibitors, FGFR receptor modulation. And then we can optimize selection, so biomarkers for selection monitoring, and next generation sequencing, blood and tumor assays. So remember, we are not just focusing on the blood, but also we may need tissue typing. The challenge is, again, we don't have a proper cell line. And whatever we have at the moment, we can grow only a little. So we have to rely hugely on the mouse model and integrate from preclinical stuff along with human tissue, and then do all the clinical trials. Because we don't have experimental cell line, that is one of the biggest limitations for targeting HCC in terms of research. So the conclusion-wise, HCC has unique gene expression, which compared to other cancers. The challenges in molecular profiling in HCC due to heterogeneity, clinical variables, intra and inter variability, and liver microenvironment. Limited tumor tissue for diagnosis due to radiographic, we use radiology all the time. Significant advances has been made, as I mentioned. However, we have a long way to go. So not amenable to drug development and curative treatment at the moment. The landscape is changing, as we have shown in last 10, 15 years. We have achieved a lot, but the systemic therapy nowadays is not just being used as a palliative care. We're using for downsizing, or also as a bridging before the curative options like surgery or transplant. So combination and multimodal therapies may offer synergistic effects are emerging to optimize patient outcome. With that, thank you.
Thank you, Dr. Jalal. We will take the question and answer session at the end of the HCC session completely. Take a seat here, please. Yeah, please. Thank you.
Yeah, so moving on with this session, we'll now be talking about newer radiological options for HCC, histotripsy and other newer radiological options for HCC. And to talk on this, we have Professor Sanjeeva Kalwa. He is Vice Chair of Radiology at the Southwestern Medical Center, Texas, Dallas. So over to you, Dr. Sanjeeva, please.
Thank you so much for the invitation and appreciate the introduction as well. Good evening, everyone. My topic is histotripsy and other neurological options for HCC management. So just before going to that, we talk about current status. So ablative therapies are very effective for tumors that are 3 centimeters or smaller. There isn't a big difference whether cryo, microwave, and RFA. We prefer to do microwave currently, mainly because single probe provides a good burn. It is not affected by the heat sink effect, unlike radiofrequency ablation. IRE is used for specific purposes where the tumors are in a central location, like in the common bile duct location or central ducts or central blood vessels, where other ablative modalities can cause more injury, where IRE can prevent injury to blood vessels and bile ducts while destroying the tumor. So it has specific area of interest in using IRE. Whereas transarterial therapy, such as chemoembolization with or without drug-eluting beads, is equivalent. However, drug-eluting bead stays appears to be much safer in patients who have poor liver function. Overall, TACE and bland embolization provide equal efficacy. TARE with the Y90 appears to be much superior to TACE, and we all have converted into TARE-only programs in the US. So then what is new? We are talking about ablations, we talked about Y90 and chemoembolization, and what is new? So these are the new therapies. Our new therapies are histotripsy, bland embolization with the newer liquid embolic materials, bland embolization with a prodrug called terpazamine, oncolytic viral therapies, and adaptive T-cell therapies. And there are modifications to existing therapies which make the therapies much more efficient and less toxic to the patient. We'll primarily focus this discussion on histotripsy. If I have time, I'll go to other therapies as well. So what is histotripsy? Histotripsy is an ultrasound-based treatment modality. It works on the principles of acoustic cavitation. When you use ultrasound for diagnostic modalities, you use short amplitude micropulses to image tissues. In this case, we use high amplitude, even micropulse repetitive sequences to destroy the cell. These pulses go into the subcellular structures and burst open the cell. It is all are focused at one location, just like as you could see here. This is how the burst happens in the tissues. It is completely non-invasive. Unlike HIFU, which is high intensity focused ultrasound, which is commonly used for fibroids or other structures or even for brain, which is focused on generating heat, and the heat destroys the tissue. Whereas in histotripsy, it is not the heat that destroys the tissue, it is the focusing of the high amplitude beam that just bursts opens the cell into subcellular structures. And it appears as a bubble cloud and can be imaged on ultrasound. So here we can targeting that tissue where you can see a focal area. So this is what it appears as you burst it, and slowly it appears hypoechoic on ultrasound imaging. One of the main advantage of this technique is you can shape the beam the way you want. You can shape an M, you can shape your own name, you can shape the size of the tumor. So you can shape the beam the way you want to destroy exactly what you want to destroy and leave around normal structures without any damage to normal areas. So again, it's a very high amplitude, short pulsing sound energy directed to target tissue. Pressure is created in the tissues, and the bubble cloud, a subcellular destruction of the target tissue occurs. You can see it very well ultrasound imaging. So this is the equipment, how it looks like. The entire thing is, the machinery is inside this box. This is a planning software. This is the arm, and this arm contains an ultrasound probe and a therapeutic ultrasound and a membrane. This membrane is a proprietary to the company, and that allows the beam to traverse into the skin and destroy the tissues. So in this area, this is what it looks like. And this is set onto the patient. This is the membrane. And this membrane and the probe are dipped in water, just a normal routine tap water. And the beam goes from the housing onto the skin. So within the housing, you can see a diagnostic ultrasound machine here. It's just a regular ultrasound probe, 5 megahertz to scan the liver. And this housing, as you can see here, this is the therapeutic ultrasound. And this contains all the elements that can produce the high amplitude short pulses. And they have electronically focused on a particular area where that area is the area where it targets. That focal point is fixed for each device. The company is making multiple of these things, but because it is focused, this fluid allows you to move up and down so that the focus zone could be on the tumor. So, and then once it is activated, you can destroy the tumor. So you see the tumor on MRI and go register with ultrasound to see where that lesion is. And once identify the lesion ultrasound, you lock the lesion and draw a line around it, confirm all the coordinates, and just activate it. And once it activates, 20 minutes later, the entire tumor is gone, and like a hypoechoic area in that burn zone or histotripsy zone. So on MRI, subsequently, you can see complete destruction of the tissue and no enhancement. And the margins are so accurate that as if somebody has cut with a blade. So as you could see in this picture, where liver is destroyed histotrypsy, the planning was 2.9 by 3.4 by 3.5. Actual destruction is 3 by 3.9 by 3.6. At a millimeter level of accuracy comes through it. On pathological examination, you can see the destroyed tissue is a lysate. It has no cellular structure like a liquid tissue there, and there's there's a clear-cut margin between the destroyed tissue and normal liver. You can see this is liquefied destroyed tissue. It's untreated tissue. You can draw a line, and it doesn't destroy beyond that point where you actually targeted. And same thing on macroscopic level as well. You can clearly see a normal liver and destroyed liver with this technique. And one advantage of this one is whatever is destroyed, body absorbs very quickly, unlike RFA or micro, it takes almost 6 to 8 months. As you could see, within 8 weeks of time, the destroyed tissue is absorbed quite well and showing the diminution of the size of the lesion. Same thing depicted on the contrast enhanced ultrasound on this image. One of the advantages of histotrypsy is that it doesn't destroy any collagen containing tissue. So it doesn't destroy blood vessels, it doesn't destroy bile ducts. So if a tumor is transgressing these structures, you can go ahead and destroy it, safely assuming that the blood vessels will not get thrombosed, the bile duct will not be destroyed, they will be functioning. So that's a major advantage compared to microwave, cryo, where you destroy everything that is in the air, including Y90 as well. So as you could see in this particular case, the lesion was destroyed, the intervening blood vessels still intact and functioning without causing any biliary obstruction either. Other advantage only destroys the tissue, but it also decreases the intratumoral pressure, allowing more uptake of the chemotherapeutic agents into the tumor. In addition to that, because the destruction happens at subcellular tissue level, the membrane antigens that remain intact and they send into circulation that elicits more T-cell reactivity and more immunogenicity of this one, which subsequently translates into more T-cell accumulation in the tumor and episcopal effect, as in this case, where the actual tumor that destroyed was totally not in this field, but all other tumors which are not even touched by histotrypsy got destroyed because of immune response that histotrypsy created in the patient's body and the T-cell activation that occurred to destroy the tumors. So you can see some reduction in the CEA as well in colorectal metastases. The first study, a Theresa trial, which involved only 8 patients, have shown that 100% technical success and 90% involution 8 weeks time of the tumor. Subsequent study with interim analysis of HOPE for liver tumor with histotrypsy involved 44 subjects, and 30 data showed it's a very safe procedure, no very minimal complications, and the primary efficacy is around 95%. Complication rate is only 7%. Subsequent, the same data, extending it to 1-year outcomes, has shown local control rate of 63%. SAEs are only 6 SAEs in 30 days. Overall survival was 73% for HCC and 50% for metastatic disease. It is still a long way to go, but the results are very encouraging that it's completely non-invasive. Any one of you can buy it and keep it in your office. Medical oncologist, surgical oncologist, radiation oncologist, anybody can buy this and keep it in your office and do it. All you need to train a technologist how to identify a tumor and focus on one tumor. You don't have to focus all tumors. It could be used as adjunct to chemotherapy to improve the uptake of chemotherapy. These are thought processes as of now. We don't know if it works or not on the areas. Another case where the kidney tumor is targeted. We are part of the kidney tumor trial by the company. So this is a case of kidney tumor there where histotrypsy was used to destroy the tumor. You can see after 1 year, there's complete destruction of the tumor, normal kidneys preserved without any problem. So move on to the next techniques we use. Tirapazam is a prodrug. Many medical oncologists might know it. It is approved for lung cancer. It was not used that well, but it works very well in hypoxic environment. So the thought process is combined with the chemoembolization, or bland embolization, and infusing tirapazam after embolization would probably potentiate the effect of ischemia and also tumor toxicity. An initial trial, the phase 1 trial, was done at University of Irvine. One of my colleagues has done it, and she has shown very good response while combining that one. The subsequent is newer liquid embolic materials. So far, we have done bland embolization using only microparticles, probably up to 40 microns in size, which can destroy the tumors. But this new liquid embolic materials, which many are coming, and one of these is called hydrogel, and it delivered into the tumor circulation with 2 separate syringes. And once they hit the circulation, they combine to form very, very fine liquid and goes to the capillary level and stays there and destroys the tissue. This is what it forms a gel in the precapillary and capillary level. And it's a bench experiment showing complete devascularization of the tumor with the complete destruction of the tumor. The company is forwarding a new trial of 150 patients to do that one. Other technique is what is called alcohol lipoidal-tase, or ablative-tase. People might have heard about injecting percutaneously alcohol into the tumor. It is very effective. The tumor is small, like 1 centimeter or so. When the tumor becomes bigger, they're not effective. So in this study, people have tried combining alcohol with lipoidal, intra-arterially injecting into the tumor, just like you do chemoembolization or bland embolization. And there's a randomized study comparing alcohol lipoidal tase versus conventional chemoembolization, and alcohol lipoidal tase is more effective in tumor control and also converting this patient to hepatectomy. So maybe in Indian environment, maybe better to use alcohol tase, which is much cheaper than drug-eluting tase. So something to think about it here. And other one is oncolytic virus therapy. It is not really tested against HCC alone. We have done a few trials in Mass General. At least I was part of 2 trials we used for HCC and other tumors as well. The philosophy is that these viral agents, like the vaccinia virus, herpes simplex, adenovirus, the ones that are injected into the tumor either percutaneously or intra-arterially, they're taken up by hepatocytes of the tumor cells only, not by normal liver cells. And in the tumor, they'll multiply and burst open the tumor cells. So it has 2 effects. Now, when a tumor gets destroyed and the tumoral antigen is released and the T cell activation happens. So 2 ways oncolytic virus therapy can help the tumors. And this is one of the studies where Paxlovid is used. You can see reduction in the tumor size with introduction of the virus intra-arterially into the tumor. This randomized trial showing a phase 2 study, which a higher dose was more effective compared to lower dose of oncolytic virus therapy, giving around 14 months of survival in these patients. Adaptive T cell therapy involves using I can stop here. Okay.
Completed.
Using either innate cells, where you prime the cells and re-inject into the body, which is really not very effective because it takes a lot of time. You can only do a few number of cells. Where engineered T cells, like a TCR or CAR T cell, which you can prepare them in the lab against known antigens of HCC, and they could be injected into the cell. So this is a mechanism how they act. This is how actual macroscopically it is present in the Harvard website. I took it, where the tumor cells are surrounded by the NK cells, causing more activation of the T cells in this area. So one of my colleagues, Lipika Goel, was part of this study where spear T cells were used against the tumor. It's a very preliminary study. We can't conclude any data, except found to be safe to use this one. The other trials going on. This is a CAR T cell therapy, a similar philosophy where the outcomes are still an evaluation, around 10% at 3 years, 40% at 1 year outcomes, a small number of 13 patients who fail every therapy available on the planet. The other trials going on, including CAR T cell therapy. Well, advances in existing therapies. One is we all do ablations. We put the probe, we ablate the tumor very nicely. We got around 90 to 95% success rate. Still, we are still short of at least 100% success rate. And what we thought was having a 3-dimensional imaging to identify the tumor morphology and burn morphology, superimpose those things to confirm that actually we got at least a 5 mm margin all around the 3-dimensional view of the tumor is important to get good response. So this is what is called a stereotactic ablation, where 3D imaging is used to accurately destroy the tumor and get the good tumor margins in ablation. Other one is a personalized dosimetry involving Y90. So initially, we all know once you hit 120 gray to the tumor, we get a good response. But subsequent studies have shown that not only 120, the higher the dose, we are close to 400, the response rates are much higher. But we have to be very mindful once you hit higher doses, a normal liver is also getting some dose. If the dose to liver increases by more than 30 gray, you get more complications, ascites, radiation to liver disease, all this happen. So we have to make sure tumors get 400 gray, but the normal liver gets less than 20 or 30 gray. So we need to develop a new techniques where we can safely deliver high doses to the tumor but safely preserve the normal liver. So this is where the personalized dosimetry comes in picture, where a normal liver, the tumor, and lung are compartmentalized and then evaluated to actually dose the tumor. So for example, in this case, the MEA is injected. Within the tumor, you can see very high uptake. Normal liver has no uptake here, but in this area, it's minimal uptake. So you take each compartment separately and plan the dose accordingly so that the tumor gets very high dose, a normal liver gets less than 20 or 30 gray, whatever you put a limit in those patients. Similarly, you can do what is called angiosomic multi-compartment model. Another one is called a voxel-based dosimetry, where you can pinpoint each square millimeter of tissue, how much the dose it gets, and calculate backwards and inject those doses to the tumor. And in the same lane, what we call a radiation segmentectomy, most of surgeons know what segmentectomy is. You go and take the segment out. So whenever we did the Y90, we did lobar, then we do selective. But radiation segmentectomy assumes that your aim is to destroy the entire segment the tumor is present. We are not selective to the tumor alone. Your aim is not to destroy the tumor alone. Your aim is to destroy the entire segment that contains the tumor. The surgeons who take segmentectomy. Here, we can give very, very high doses of 400 or 500 gray to the segment, and the whole segment evaporates and nothing is left. So just like surgeon has taken over the segment. It's a very effective, 100% tumor response. Pathologically, you will say nothing in the area, complete pathological response. So an example of one of my cases where caudate lobe tumor, which is a caudate lobe tumor, selectively catheterized the caudate lobe artery. You can say entire tumor enhancer. This is the MEA scan. And once we gave extremely high dose of 400 gray, entire tumor has disappeared and nothing left in that area. So good response rates, the overall survival, if you do for smaller lesions up to 5 centimeters, is around 6.7 years, equivalent to surgical resection in this patient population. The same thing adopted towards what we call super selective TACE, similar to ultra selective chemoembolization we used to do with the regular chemoembolization material. Here we use Y90, where we do multi-dose models. We use like a 3, 4, 5 models. You selectively catheterize each segmental artery and then inject very high dose only to the tumor and preserve the rest of the parenchyma. It is now more of a standard therapy for us now. So an example of a case which I have done, the tumor is separated by both the right and left hepatic artery. Those segmental arteries are catheterized, only tumor is enhancing, and post you can see the tumor is very small after 1 year period of time. Next one is the combination therapies, where we have combined RFA with chemoembolization or chemoembolization, other things. Before the advent of more effective drug therapies on Y90, the most combination therapy is chemoembolization with RFA, which is very effective up to tumors at 5 centimeters. It is not very required for 3 centimeters or smaller, but as you go to between 3 and 5, where the benefit appears to be more present. The same thing is true whether you do TACE or when you do RFA. Once you hit between 3 and 5 centimeter size, combining is always helpful in those patient population. Same thing with whether you do microwave or RFA, both the same results. And when you combine TACE with RFA, how good it is compared to surgery. Up to 3 centimeters tumors, no difference. Outcome, local recurrence, overall survival, whether you do resection, whether you do combination of TACE with RFA, they're exactly same outcomes. But once you go above the level 3 up to 5, surgery has a slightly better outcomes, long-term survival. Local recurrence is almost the same, but surgery has one complications, longer-term hospital stay. What about systemic therapy? I think the previous speaker talked about some of the systemic therapies that's available now. People have tried sorafenib with TACE, with RFA, and Y90. Have not shown to be effective combining these therapies. There wasn't any advantage of combining sorafenib with any of these therapies. Okay, thank you.
Okay. Thank you, Dr. Sanjeeva, for showing us the entire spectrum of newer advances. We'll have questions at the end if time permits. Please be seated on the dais.
Thank you. Now I have the privilege to call upon Dr. Richard Finn, who is a hematologist and a medical oncologist at UCLA, to talk about maximizing patient outcomes in unresectable HCC. So as we know that most of the patients are unresectable and advanced stages. So Richard has a lot to show with immuno as well as other combinations. Thank you, Richard.
Okay, thank you very much for the invitation. For the record, we're running late when I started, and I know you have your reception, and I have a lot to go through, so we'll get right to it. Thank you very much for the invitation, and thank you to the Roche team for sponsoring the symposium. These are my disclosures. So when we talk about liver cancer, staging is important. You heard that earlier. And not to belabor the BCLC, but it is prognostic. Unresectable liver cancer is mostly intermediate and advanced. Intermediate has a better prognosis than advanced. And intermediate, the backbone has been local regional treatments because these are tumors confined to the liver without vascular invasion. Now, we appreciate now that there is probably a group of patients who are intermediate who are better served by medical treatment. And all the groups here highlighted by the red circle are those that we should consider for medical treatment. The advanced group, extrahepatic spread, macrovascular invasion. Also, those intermediate patients who have diffuse infiltrative tumors, bilobar, multinodular tumors. And keep in mind, patients become resistant to LRT, just like they become resistant to drugs. They progress, and at that point, medical treatment should be considered. Now, there's been globally 6 large phase 3 studies. I'm going to break these into different flavors. Initially, we had the receptor tyrosine kinases, sorafenib and lenvatinib. Then we've had an explosion in immune checkpoint inhibitor-based doublets. Those come in different flavors. There's atezo-bev, which is VEGF and PD-L1. Then the 2 CTLA-4-based regimens of durva-tremi and ipi-nivo. And TKI and PD-1, the rivasirnib and camrelizumab study. But not all of these studies are the same when we look at the patient population, and that's critical when we assess the activity. One of the most important prognostic factors in liver cancer is main portal vein invasion. And only IMbrave 150 and the CARE study included patients with main PVT. So the primary endpoint in these studies is typically overall survival, sometimes PFS included. And you can see that with atezo-bev, a hazard ratio of 0.58 represents a 42% decrease in the risk of death. Both the CTLA-4 combinations give about a 22% decrease in the risk of death. And the RTK study, rivasirnib, camrelizumab, also very active with 0.38. Now you have to keep in mind median survival, again, in the context of the population being studied. Even with main PVT, atezo-bev gave us a survival of 19.2 months. Durva-tremi, only 16.4 months in a better cohort of patients. And Checkmate 90W gave 24 months. And again, this is in a better cohort patient, and I'll go into these studies in a little more detail. And then only atezo-bev and the CARE study improved PFS. We don't see that with the CTLA-4 combinations, and the response rates you see on the bottom there for the active regimens, again, in a high-risk population, 30% versus 20% and 36%. So when we look at the IMbrave study, it was stopped at an interim analysis because both PFS and OS hit their primary endpoints. And you can see when you look at the PFS curve and the OS curve, these curves separate very early and remain separated. Now, the initial study was stopped with 8.5 months of follow-up, but with longer follow-up, median 15.5 months, we see that the 18-month survival of 52%. Keep that number in mind. We do not have longer follow-up because the study was stopped. It was positive and it read out the drug were approved. Now, I mentioned this high-risk and low-risk population issue. Now, when we take out the high-risk patients, retrospectively, we see the survival is actually 23 months, very similar to the favorable population in Checkmate 9DW. However, high-risk patients still have a problem because even with atezo-bev, survival is only 7.5 months. But the magnitude of benefit is very similar, 0.62 and 0.68 when we look at the hazard ratios. But these factors are prognostic because look at sorafenib here, 5.5 months versus 16 months. So the high-risk patients do poorly regardless of how they're treated, but they still get a benefit. Now, toxicity with atezo-bev is mostly driven by the bevacizumab. We see hypertension and proteinuria. Obviously, atezolizumab causes immune-related adverse events, but when combined with bev, it's about 10 to 12% of patients who need steroids. And this side effect profile is much more favorable than we see with sorafenib, where patients have diarrhea, hand-foot skin syndrome, and the quality of life data from the study supports this observation. Now, here we're looking at treatment-related adverse events. You can see compared to sorafenib, there's less with atezo-bev of all grade. Treatment grade 3-4, favorable versus sorafenib. SAEs, about the same. There are more treatment-related deaths, but only 2%. Keep that number in mind, because when we look at the other regimens, it's very comparable. And only about 7% of patients, less than sorafenib, had to stop the regimen completely. Now, bleeding is a concern for everybody here, I know, in GI and hepatology. All patients on this study had to have upper endoscopies within 6 months. And with that being said, we saw that about a quarter of patients, 26%, in both arms had known varices, and a number of them had them treated. And the criteria for the study was just that they needed to be treated based on local requirements. With this being done, we see that grade 3-4 bleeding is very similar between atezo-bev and sorafenib, 6.4% versus 5.8%. Most of the bleeding we see is low grade, epistaxis, hematuria, gingival bleeding, and these are higher than sorafenib. But obviously, we're concerned about the high-grade events, grade 3, 4, and 5. And when we see the grade 3, 4 events for GI bleeding, there's about 3% with atezo-bev and 2.5% with sorafenib. Now, there are more deaths from bleeding events with atezo-bev. There's 4 versus 0. But these 4 events actually occur all in the patients with main portal vein invasion, in that high-risk group of patients, because they have more portal hypertension. With that being said, they still get a benefit to treatment, as we demonstrated. And we now have real-world data. This is one of the studies from Europe that looked at cohorts of patients treated in various clinics, and survival with Child-Pugh A patients, 17 months, very comparable to what we saw in the phase 3 study. And the bleeding events are very similar to what we saw in the phase 3 study, and they showed here that bleeding events occurred regardless of patients had varices, grade 1, grade 2, or grade 3 varices. The frequency and grade of bleeding was the same regardless of the baseline endoscopy, and there was really no difference in the frequency and severity of bleeding between Child-Pugh A and Child-Pugh B. Now, the Himalaya study was a positive study. Hazard ratio was 0.76 or 0.78 at the primary analysis with an objective response rate of 20%. Median survival was 16.4 months with the combination of a single dose of tremelimumab to a CTLA-4 antibody. In this study, the curves separate later, likely reflecting a more favorable population. At 18 months, they have 49% survival, very comparable to atezo-bev. And they've presented long-term survival data now out 5 years, keeping in mind there's a limited number of events, but 20% of patients are alive with STRIDE versus 9% with sorafenib. But in order to get to this point, you need to get beyond 6 months, 12 months, 2 years, etc. And we don't know who those patients are. And we do know that the median PFS is the same between sorafenib and STRIDE. And interestingly, we need to be very careful when we look at these landmark analyses. I presented this data at ASCO a few weeks ago. And as you know, the LEAP-002 study of len-pembro versus len-placebo was negative, right? Hazard ratio is 0.84, 21 months versus 19 months. However, with longer follow-up, and here we have up to 36 months, there's still a number of patients censored, even up to 4 years. You can see that there's more patients alive with len-pembro versus lenvatinib alone, 33%, which reflects that probably with all of these IO regimens, there's a subset of patients who have long-term survival, even in a study that was negative for its primary endpoint. And that's why the primary endpoint is most important, which is basically the risk reduction in the hazard ratio. You also see in PFS, 20%, once you hit 2 years, there's about a 20% tail where patients are not progressing. Now, safety and toxicity with Himalaya is really driven by immune-related adverse events. You can see here that it is very favorable compared to sorafenib as far as treatment-related adverse events and frequency, but the death rate is the same as with atezo-bev, treatment-related deaths, 2%, 2.3%. The cause here is more likely immune-related, as with atezo-bev, maybe some of those are bleeding events. But at the end of the day, the amount is the same. And it's very interesting to see the biology here. Whereas durvalumab did not improve survival versus sorafenib, a single dose of tremelimumab and durva did. It increased the response rate. However, it also doubles immune-related adverse events. And single-agent durva, 9.5% of patients required high-dose steroids, very similar to atezo-bev. However, with a single dose of tremelimumab, that becomes 20%. And many of these high-grade events are hepatic events, diarrhea, colitis, etc. Now, Ipi/Nivo was approved in the US in frontline a few weeks ago. This regimen also improved overall survival. Here you see a hazard ratio of 0.79. Unlike the other two studies, 85% of patients in the control arm here had lenvatinib, not sorafenib. But you can see Ipi/Nivo survival of 24 months in a better prognostic group of patients, no VP4 invasion. And keep in mind, lenvatinib in this study, mostly lenvatinib, 20 months. And actually, in the LEAP-002 study I just showed you, it was about 20 months. So lenvatinib is an active drug in liver cancer. But look at this curve here, right? We could say the benchmark, landmark at 3 years is 38% survival, very similar to what I just showed you with STRIDE and with LEAP-002. But if you're going to look at 36 months, you probably also have to look at 6 months. And this curve is very strange because for the first year, lenvatinib is actually doing better. And then the curves tend to flip. Exact reason driving this is not completely clear to us. Presumably it's toxicity. Because when we look at treatment-related adverse events, again, driven by immune-related mechanisms, we can see that it's very different than the TKIs. We're not seeing as much hypertension, hand-foot skin syndrome, but we're seeing diarrhea, pruritus, enzyme elevation as well. And treatment-related discontinuations here is 18%, quite higher than what we saw with atezo-bev or with durva/tremi. And the death rate here is 4%. Again, double what we saw with durva/tremi or atezo-bev. But this is an active regimen. I mean, the objective response here was 36%. And here you see the need for steroids is up to 29%. So we go from 10-12% with atezo-bev or single-agent IO, 20% with a single dose of tremelimumab, and now with Ipi/Nivo up to 29%. And you can see a lot of these grade 3-4 events are liver-related. So I'm moving pretty well, I must say. I'm almost done. I want to talk about intermediate disease, which ties in well to the previous talk. And I commented that we appreciate that maybe not all intermediate tumors are appropriate for LRT. And there's been several concepts put forward, one of them being beyond up to 7, where the size of the largest tumor plus the number of tumors is greater than 7. But we also know on imaging, while all these tumors might look and be staged as intermediate because they don't have vascular invasion, they don't have extrahepatic spread, clearly their size and pattern is not going to benefit from LRT the same. And keep in mind, when TACE was developed versus placebo, these were very defined patient populations. And without active drugs, as you saw earlier, in the development of treatment of liver cancer, LRT expanded to fill a void. But that needs to change now because we have very active regimens that have been shown to improve survival. And I just want to point out here, when we look at the intermediate patients in IMbrave 150, their objective response was 44% with atezo-bev. Keep that number in mind. Because earlier this year published was the Emerald study, which was durvalumab and bevacizumab with TACE versus placebo and TACE. Primary endpoint being PFS, hazard ratio 0.77. You can see here the curves separate rather late, but then remain separated. We're still waiting to see overall survival from this study. Importantly, in this study, the BEV was started after the initial TACE treatments. Durva was started before, but BEV was started later. And keep in mind, TACE induces ischemia. Ischemia induces hypoxia. Hypoxia induces VEGF secretion. And that is part of the rationale of using VEGF-targeted drugs. Now, the objective response here was 44%. It's unfortunate that there was not a systemic treatment alone arm here, because I showed you before with intermediate patients, atezo-bev had 44%. LEAP 012 looked at len-pembro, also positive, hazard ratio 0.66. In this study, the len and pembro were started before the TACE. The curves separate early and remain separated. And again, the objective response rate, 47%. It'd be very nice to have a medical treatment alone arm in these studies. And we do have some preliminary OS data here, hazard ratio 0.8, not statistically significant, but you can see there's still a lot of censoring. And a few weeks ago at the ESMO GI meeting, we saw Talent TACE, which is atezo-bev and TACE. They had a novel endpoint of untaceable progression, and this met its endpoint with a hazard ratio of 0.71. Looking at more conventional PFS, hazard ratio 0.64, very similar to the LEAP study, right? 0.66. Primary endpoint of OS, not reached yet, but a trend. Not reached yet because it's very immature, right? There's still a lot of patients here. We haven't reached median survival. Right now, it's about 3 years median survival, and we haven't reached the upper limit. And again, here, the objective response rate, 49%. Very consistent themes, I think, across all these studies. So in conclusion, for unresectable liver cancer, IO doublets are the standard of care. Several regimens have level 1 evidence, but only atezo-bev has consistent improvement in OS, PFS, ORR in patients with high-risk features, main PVT. Local regional treatments have been the backbone for B, but now, increasingly in the US, we're using Y90, and now we are seeing signals of systemic treatment with LRT that it may be improving outcomes for patients, and we're waiting for further data on that population. I want to thank all my colleagues at UCLA who are so supportive, and thank you very much for having me.
Thank you very much. Do you have time for some question? Any question from you? No?
Can I ask Prasoon one question? You see, since you have reviewed the whole molecular pathogenesis, do you think the number of mutations in early HCCs, which you call BCLC-A or BCLC-0, and in comparison to BCLC-C or BCLC-T, where the advanced HCC, where you are using IO with anti-angiogenic drugs or IO and IO, the degree of mutations are much more. That is what the concept is. And do you think now, even though loco-regional treatment using ablative therapy, various energies, now this is histotripsy is a new energy, or already besides the other already established therapy, the IO or the anti-angiogenic therapy, which is less mutation, will be effective? Is there any data?
I'll definitely hear Dr. Finn's comment on that, but I strongly believe that combining systemic therapy with LRT eventually would provide good results. So far, I don't think the data is strong, but I strongly believe that reducing tumor burden, combination therapy is definitely one way to go. What's your opinion about it?
Yeah, well, excuse me. for all the molecular work that's been done so far, it hasn't impacted clinical decision-making. And there is a lot of rationale to combine LRT with systemic treatment, but that's why we need to do clinical studies, right? I mean, we are seeing a signal with PFS. I don't know that we'll see overall survival benefit from those studies because that's something that can be very hard to prove. Many of us, I think, are taking the idea of maybe starting with medical treatment and maybe then moving to LRT as a consolidation, Y90 for patients who have a good benefit. There's a lot of scientific rationale, like I said, with the VEGF expression and inducing ischemia, or we'll have to see. Histotripsy is very young, right? But there's an idea there that's being generated, but that's why it's so important to do clinical research, because without it, we're just waving our hands.
IMREB 50 has shown after ablative therapy, the recurrence rate is less. It's IMREB 50, that is preventive recurrence trial.
The adjuvant study.
Yeah. So obviously after ablation, if you use, immunotherapy plus anti-angiogenic therapy, the recurrence rate is coming down.
That was a negative study, IMbrave 050. There's probably a subset of patients who do benefit,
right.
and maybe you were commenting on the molecular diagnostics to identify those patients who benefit rather than just pathology. I think we're kind of stuck until we have some data like that.
Any other question, Ajay? Yeah.
Yeah, I think I must compliment all the three speakers. Wonderful talks. I think too much of learning here. I think Dr. Finn, I think probably it has been largely answered from the data, but then what are your thoughts on the use of immunotherapy in viral versus non-viral etiologies? Does it really matter?
No, it doesn't matter. And, I only had 15 minutes, so I had to be selective. A lot of that came from a lab-based study that then tried to look at clinical data. And just to be very brief, if you look at the IMbrave 150 study, the objective response rate, regardless of viral or non-viral, is the same. 27, 28, 29%, right? So if it wasn't going to work in that group, you'd expect the response rate to be very low. The hazard ratio for OS and non-viral is 1. But that is because the sorafenib patients in non-viral had a survival of 18 months. But there were only 50 patients in that group. So with a small subset, no one expects sorafenib to give 18-month survival. So it's probably just an artifact of not stratifying, having small subgroups. So I think that kind of steered the field off on a red herring, as we say in the US. But I don't think etiology should be used to select patients.
But I have a question in the same context. But you don't believe that MASL-related HCC has got a poorer response to immunotherapy at the moment?
Well, first of all, no one classifies patients as being MASLed or NASH, right? It's non-viral because we don't collect that when we do these clinical studies. Use the word believe. This is clinical research, not religion. And I have facts that tell us that these patients, at least non-viral, respond the same.
It's very difficult to say, Dr. Finn. In your study, it was predominantly Asian patient with viral etiology. And therefore, your odds ratio for decreasing HR will be very difficult to assess between the two groups, isn't it?
Again, the study wasn't designed to answer that question, right? This is all done retrospectively. But ongoing studies are stratifying by etiology. I'm pretty sure the Ipi-Nivo study did. And again, it's non-viral. No one can say NASH because you're all the liver doctors. It's very hard to make that diagnosis unless, it's just based on clinical characteristics, right? Diabetes, the lack of hepatitis, a lot of NASH and alcohol overlap. So,
Richard, one last question.
And this is the last question.
Yeah. What is your take on combining SBRT in high-risk patients where you have PVTT with IOs? Because we are doing a lot of it this in our center.
Yeah, I'm not convinced that there's a benefit there. Again, personally, I've done it a few times when patients are doing well and their thrombus might be the only measurable disease that's growing. I've never seen any dramatic effect. That's anecdotal, but even the clinical studies that have been done are usually single-arm studies. I don't know that it adds anything, to be honest. I'm not convinced. But again, we need data.
Okay, now, Dr. Kalla wants to ask the last question.
Yeah, Dr. Sanjeeva, IRE versus histotripsy. So, yeah.
Well, we still have to get more data on histotripsy. But if it is to be as good as it seems in the beginning, probably we'll move towards histotripsy, mainly because it's completely non-invasive. We don't have to put 5 needles into the body to get IRE, and it is safer, so it could be used by anybody. I think that alone makes it probably a better choice than IRE if it works.
Thank you. I think no more question. Our secretary is showing me signals. Close it.
Thank you.
Okay, thank you very much, all of you. Brilliant talks and a lot of learning points. Thank you very much.
Thank you to the chairperson speakers. Please join us for the photograph.